So I don't know what about what. He just said, you need to go talk to Ron. We met at the dinner. As you recall. Yeah, and he said, yeah. you should go talk to him.
It was actually a tremendous difference. It was
And we've tested it multiple times with pasta.
Thank you. So we're a little behind schedule, but our next presenter is already up on the big screen, and I apologize to her. I apologize to Dr. DeBiasi for the lateness. We had a tremendous panel just before. I don't know if you were able to catch it, Doctor, but it actually sets you up very well. We tend to do those things, or at least we try to here, because we talked a lot about, in the closing minutes of our last panel, we talked a lot about age groups and younger people who get afflicted with Lyme and other tick-borne diseases. And so right now we're going to have a pediatric Lyme update. Clinical pearls, she calls it, outcomes and research. Dr. Roberta DeBiasi is a Children's National Hospital in Washington. She is here. We have video and audio. And so, Doctor, the floor is yours.
Great. Thank you so much for the invitation to speak at your meeting. I apologize I couldn't be there in person. I'm actually on the inpatient service here at Children's National, and I couldn't break away, but I hope I get to visit some other time. So I was asked to give a little bit of clinical pearls that are specific to pediatric Lyme, because we see a lot of children with Lyme in the Mid-Atlantic, and then share a little bit of the research that we're doing, looking at outcomes of pediatric Lyme, as well as some other pediatric specific research topics, including the potential for pregnant women to transmit Lyme to their fetuses. So, I'll start with, and I'm sorry, some of this might be slightly repetitive, but it's just a few background slides just to make sure we're all on the same page. We all know that Lyme in general has been increasing. If we look at CDC data, there are many cases, and these are just the ones that are reported. But many people don't appreciate that up to a third of the cases occur in children, and particularly in the 5 to 9-year-old age group is our highest peak of cases. It's a very frequent consult to both our outpatient clinics with kids at all stages of Lyme or tick exposure, or our inpatient service for kids that have either meningitis or arthritis related to Lyme. Those are the two most common diagnoses. And just to give you an idea of the volume, when we were preparing to do this research a while ago, we did a 10-year search for at the time, ICD-9, and then moving into ICD-10 codes for Lyme. And there were over 1,000 kids in that 10-year period just at our center alone. So, about 100 kids a year that are being seen at our center. So this just reminds you that, the incidence has steadily been increasing, both due to awareness, but also, people increasing the reporting. You see there's a little drop off in 2020 and 2021, but that's likely related to COVID. So, I doubt that the incidence is decreasing. I think that's more of a reporting. But this slide really is visual to show you, if we look by age on the x-axis and just sheer number of cases that are reported, and then broken into male and female, we have this huge peak of cases in the kids that are in this 5 to 10, but even going out into adolescence, 15-year group. And there is a predominance of male over female, but it's high in both. And that's, higher than any other age band. Of course, there are more adults across the entire age range from 21 to 80, making up the other 70% of cases. This is just another way of looking at that by percentage of total cases. So if you look again by age band across the bottom axis, and then the percentage of total number of cases reported in the US, you see this big blip at the 5 to 9 age group, which again is equal to the percentage in these older age groups. So you all, this audience, are very familiar with the different types of presentations, and I was asked just to comment on, do we see the same thing in children, and is one more common or less, or do we not see some of these things in kids, or are there anything unique with kids? So just to set the background for that, overall, meningitis encephalitis is about 2% of all Lyme, whereas the vast majority is the erythema migrans rash with 70%, and then arthritis coming in second place with almost 30% of the cases. And then facial palsy somewhere in between, with about 9 or 10%. The rarer presentations are radicular neuropathy and carditis. So if we then take a look at that in kids, whoops, my finger is moving too quickly here. We certainly see kids that have recognized tick bite, they go to camp and whatnot. And we see kids in the ER that come in or into pediatric offices that have a erythema migrans rash. So I think that's very similar to what's seen in adults. But we see a lot more meningitis in children for whatever reason. So up to about 30% of what is referred into the hospital or that are seen in ERs can be Lyme meningitis. And one of the unique presentations that is not seen in adults is we'll see children that come in with headache, progressive headache, and they'll get a lumbar puncture if they have neck stiffness or just really severe headache. And we can, on exam, see increased intracranial pressure and actual papilledema, which we call pseudotumor cerebri, where they don't actually have a mass lesion or anything causing the increased pressure. And that finding can actually precede seeing actual white blood cells in the spinal fluid. So we consider that, if we see that finding, even if we don't see pleocytosis, we will treat those children for Lyme meningitis. Carditis is much less common in children. Radiculopathy and mononeuritis multiplex are very uncommon. I can, many years of treating these kids, I can think of a handful. Cranial neuropathy, I think, is pretty similar. We see it, here and there, but again, it's not the primary presentation. So I do think, like children, like adults, arthritis is pretty common. Erythema migrans is very common, but I think we see more meningitis and we see some unique types of how those kids present. And then, related to the research that I'm going to talk about, no one really knows the true incidence of post-treatment Lyme disease in children. And that's what we're trying to get our arms around in some of the research that we're pursuing. So, what are the knowledge gaps for pediatric Lyme disease? Objective data regarding just the natural history and the long-term outcome is very sparse. Kids are included in many studies that are done in adults, but they're usually a small percentage and it's a mixed population. So there's very few that are really dedicated to just children. Very few studies have attempted to really look at the incidence of PTLDS in a purely pediatric population. And then equally important, the pathogenesis of the children who have these post-treatment, beyond 6 months symptoms. Very little is known about what's causing it, the immunologic responses, whether or not there are biomarkers that could give us a clue to what might help treat these children. So that is the knowledge gap that we've been trying to start working on at our center, because we do have a significant volume of pediatric Lyme patients. And this was a pilot study that we did. Dr. Chesson was a resident at the time who worked with our team, and he tried to look at specifically children that had meningitis or arthritis. So these were all hospitalized patients for which we had very rich and detailed clinical data and very good lab confirmation. And I just wanted to preface my comments for the rest of my talk. When we talk about research, we try, when we do our initial pilots or our initial studies, to really get a homogeneous population so that we can make conclusions. But that does not in any way mean that we think only people with CDC criteria, Lyme, antibodies have Lyme. So I just want to say that up front, because sometimes people get frustrated. They're like, well, why aren't you including everyone in your studies? And I think it's really important when you're doing a pilot to restrict the population to those that are, kind of the classic form, and try to see if there's something going on there first. And then it can certainly be expanded, or to design the study so that you're at least able to distinguish those two groups and make sense of the data later. But for this study, these were, absolutely, no one would have any discussion about whether or not they really had Lyme or not, and whether or not they had meningitis or arthritis. And what we tried to do here is try to determine, is there any correlation between how long they had their symptoms prior to showing up, getting the appropriate diagnosis and the appropriate treatment, and how long it took them for their symptoms to go away. Because what we see as clinicians is parents, no matter what stage their children are at, whether it's just a tick bite or a rash or meningitis or arthritis, they are panicked that their child is not going to recover. And part of that's appropriate because there are a small percentage of children that don't, that do have prolonged symptoms, but it's been our experience that the vast majority, once they are diagnosed and treated, do very, very well. So we wanted to try to start to get some objective numbers so that we could guide families. Like, for instance, if you have meningitis, whether you were 7 days before we got you, 2 weeks, or over 2 weeks, these children got better within 3.5 days of their treatment. So if they're still having symptoms 7-10 days later related to their meningitis, that's out of the norm, and we should look for other things besides the Lyme. On the other hand, for arthritis, if you were less than 7 days of symptoms, it still took 12.5 days for them for their knee to be better. Whereas if they had a week or two or even 2 weeks of symptoms, it could take a full month for them to have resolution of their swelling. And this is really important for setting the expectation for the family, but also for the docs, so that they don't say, well, we've got to try, all these other things. Let's work with the initial therapy first. And this is the expectation, but that they will get better. So that was the point of this initial pilot study. And it was exciting enough and well received by all of our patients that we decided to do a bigger study. And we have a partnership at Children's National with the National Institute of Allergy and Infectious Disease that is beyond Lyme. It now includes Lyme, but it's our research institute. And because we have mutual interests in a variety of autoimmune, allergic, and immunologic and infectious disease conditions, we have partnered because each institution has strengths that can be leveraged together and get to some answers. And so this is a study that we embarked on a few years ago. It has 2 aims that I'm going to share with you, and then I'm going to share with you the paper that we just published regarding the findings from the first aim. I am the PI at Children's National, and Adriana Marquez at NIH is the PI at NIH. And we have a very talented team, including Maureen Monahan, who is our PhD psychologist on this study. So aim 1 is the one we've completed, and this was to really get a good idea of the long-term quality of life and cognitive outcomes of pediatric patients with all stages of Lyme. And we knew that we had, 1,000 kids that we could potentially try to approach, and we did. We approached them all, but we were hoping, as we know in these studies, to get 1 out of 10 and get 100 kids to have some power to make some, conclusions. And we were successful in getting 102 children into this study. They range from 6 months to 10 years ago when they had their diagnosis. And then we did a variety of validated age norm, parent, and self-report questionnaires that many in this group, I'm sure, are familiar with. These are specific to children, and we limited it to the children that are 5 to 18 so that we could get both parent and child report data for which this is validated. And there's the child health questionnaire that looks at health-related quality of life, the sluggish cognitive tempo scale, which looks at cognitive function, and the PROMIS scales, of which there are many, but we selected pain, fatigue, and mobility as the ones most pertinent to post-Lyme syndrome. The second aim, which we are just starting to embark on, is then to having identified a group with prolonged symptoms, compare those that cohort to those that fully recovered, and then also with healthy controls. And we've learned, one thing we learned from COVID studies, we've had a lot of post-COVID, we have about 250 kids we follow in our center for post-COVID or long COVID. It's really important to have a healthy control cohort, because there are many things that are abnormal that occur even in children that have never had COVID. And that's also true with the case with Lyme. So I think you're all aware that there's much increased levels of anxiety, depression in children in general because of the time that we've been through. So whenever you're doing a study, if you want to attribute whatever you're finding specifically to the disease process, you have to have that healthy control cohort as well. And for these 3 kids cohorts, we were going to bring them in prospectively and do detailed neuropsychological assessments, looking at cognitive function using the NIH toolbox and the brief assay, but then also draw blood biobank and then be able to do some advanced immunologic, genetic, and transcriptome analysis to try to find, okay, what is different about the group that doesn't recover, and could that give us some clues about targets for treatment? So, see if I can advance here. This is the paper that we just published earlier this year that describes the results of that first AIM, where we approached the 1,000 children and enrolled 100. And Dr. Monahan was the first author on that. And this just goes through on the right, the reasons why people did not participate. So we did approach them all. Some did not have the truly confirmed, lab confirmed. And as I said, that doesn't mean that they didn't have Lyme, but for the purposes of this study, we did not enroll those patients. So that was about 300 patients. If they had significant underlying other medical illnesses that might cloud the analysis, we removed them and did not enroll them if they were too young. So that alone, those three were the most common conditions or reasons why they were not enrolled. And that was about 600 patients. And then about another 300 had really incomplete medical records. And for this, we wanted to have very detailed information. But for those that were not enrolled, we still wanted to include them as a control group because we wanted to make sure that the people that were enrolled were not significantly different from those that did not enroll. Otherwise, you don't know, if you're getting a skewed population. And so we got information about their treatment, their diagnosis from the electronic health record, because these are all people that were cared for at our center and our clinics. And then the parents and the children of appropriate age completed these validated assessments. So I'll just walk through a little bit with you, what the population looked like and what the findings were. So on the right, it says 96. This was a nice graphic that we had. It's very similar when you put in the whole 102. But we had a really nice distribution of all the age bands. So about half were the 5 to 9-year-old group. We had another 33% that were 10 to 13 and about 20% that were the 14 to 18-year-olds. And then similarly for the age that they were at when they were actually diagnosed, it was enriched as we would expect for the 5 to 9-year-olds, but still we had a nice percentage of kids that were in this early adolescent group and a smaller number in the 14 to 18-year-old group. And when we compared the 102 that were enrolled in the study to those that did not enroll, because we could still get that information from the medical record, it was very similar. So, about 60% were male. The age at the time of diagnosis was similar, although slightly older in the non-enrolled group by 1 year from the median. The time, we couldn't assess the time since initial diagnosis to compare that, but the ethnicity was different. We had 73% white children that were enrolled, whereas those that were not enrolled, it was 45% white and a higher percentage of African American. For our Latinx, it was similar, 80 versus 77%. And then we felt that this was important so that we could compare the two populations. Then likewise, looking at the stage at the time of diagnosis for enrolled and non-enrolled, it really was not significantly different. And we had a nice distribution across all stages, both localized, early disseminated, and late. So the results, there was a lot of rich results, but in the short period of time, I just wanted to give you the highlights. We found that the majority, which is 75% of the parents reported that their children's symptoms resolved completely within 6 months. But really importantly, it was variable as to how long it took. So about a third said it was within a month. Another third it took 1 to 3 months, and 14% it took 4 to 6 months. And then importantly, and I think this alludes to, because I did catch the end of the discussion from the prior talk, 22% of kids, the parents indicated that their child had at least one persistent symptom after 6 months after adequate treatment. And what we tried to do is separate these into which would meet the full post-treatment Lyme disease syndrome definition, which means that you have the symptoms, but you're also functionally impaired, meaning for a child that you can't do the activities you usually do, you can't go to school. Compared to those that have them but are soldiering on, and they're mild enough, or not mild but moderate enough, that they can still do the things that they usually do, but it's bothersome. So of the 22% who had these prolonged symptoms, it was 13% who were still able to carry out their usual activities, and 9% though that had significant impairment. And so I think this is a small initial study, that number 9 or 10% is in range, which has been found in some adult studies, but in general, I think that's a lower number than has been seen in adults, where it's up to, you know, some studies say 30–40% of adult patients can have prolonged post-treatment Lyme disease symptoms. And I would say this is consistent with what we see in our clinic when we're treating our patients, that we feel that most of the patients do seem to respond. But it's very, very important to realize if someone is not responding, that this is a true entity, that these patients should not be dismissed, and that we need to focus on the mechanism by which this is occurring so that we can find some treatments to help them. So, we tried to look at the duration of symptoms and the durations of symptoms, prior to diagnosis, and the duration of symptoms until recovery, just like we did in the other studies. And we tried to characterize that so that there would be more rich data to share. And it was very similar to the pilot study that I explained. And the takeaway being that it can take longer, particularly if you have late disease, so that families are not frightened by the fact that it's taking longer for the symptoms to resolve. But I wanted to focus in on the children that had the post-treatment. So of these 22% that had at least one symptom persisting over 6 months after their treatment, these were the most common. So fatigue, musculoskeletal pain, cognitive symptoms, and depression. So that's, I think, similar to what's seen in adults. But we also, could analyze just free text write-in responses. And these were some of the other things that children with these symptoms, the parents noted. There were nightmares, mood swings, some with decreased appetite, headaches, some with high fevers, some with anxiety, and then stomach pain, abdominal pain. And we've actually seen this abdominal pain kind of phenotype in our post-COVID children as well, which I think is somewhat different than what's seen in some of the post-infectious syndromes in adults. If we look at the group that had prolonged symptoms, I alluded to this in the prior slide, 59% of that group, it did not impact their functioning. We call that symptoms. 41% though, which is 9%, the number I showed you before of the total sample, it did, meet the criteria for post-treatment Lyme disease syndrome, and had significant impact on their functioning. And then we tried to analyze, could we predict either by their sex, their race, their ethnicity, their age, the stage of Lyme, how long they had symptoms before. Is there any way we could predict who would get post-treatment Lyme disease? And really the only thing that fell out were that older children at the time of their diagnosis were more likely to meet the criteria and to be part of this group that had prolonged symptoms. And that was statistically significant. Everything else was not correlated. So it didn't matter if you had early or late stage. It didn't matter if you got the correct treatment right away or if it was delayed. It didn't matter your sex, race, or ethnicity. And the other thing that we noticed, and we know this from our own clinical care, is a third of the children with post-treatment Lyme and 22% with the full-blown syndrome with affecting function used adjunctive therapies of one kind or another, which is important to understand and to be able to, in studies, to assess if that's affecting outcomes. This is a little bit probably beyond what you all care about today, but if you're interested later in the paper, there's very detailed information that Dr. Monahan presents that looks at all the specific scales and what the findings were, trying to compare the kids that had the full-blown syndrome versus symptoms versus no prolonged symptoms on each of these different validated scales. What I will point out is the one that fell out as statistically significant was fatigue. So on that PROMIS scale, fatigue was the most likely to be different between those children with the post-treatment Lyme disease syndrome versus either just symptoms or no symptoms. And then this graph, I think what's really unique about these pediatric scales is we can directly compare the responses on any of these domains. So this is for mobility, fatigue, and pain. We're looking at the parent response and the child response. And these are, we call these balloonograms, but what you can see is a T-score of 50 is the median. And we get really nice congruence between what parents and children are reporting in most cases, but there are instances where there is discrepancy. And it's really important to capture both. We haven't published yet the information I showed you was based totally on parent report, But for instance, in this subject, the parent reported that this child had very good, no problems with mobility, but the child felt that they, were not very mobile. There was a big discrepancy. The vast majority, it matches up with the horizontal line, but there's definitely differences in perception of parent and children. And that may have something to do with either the disease process or the age range that they're in. So, the overall impact of this study is we're hoping to have more objective data, which is really lacking now for really all presentation stages, inpatient, outpatient, pediatric Lyme, to share with patients and their practitioners out in the community so that they're educated and have information that they can access beyond the internet to get an objective determination of what the incidence truly is of this post-treatment Lyme syndrome in children, which definitely exists and needs to be recognized. And we have to be able to help these children and families because it can be very debilitating, as you alluded to in the prior talk. To have objective analysis of cognitive function, motor function, and quality of life, and then to build a biorepository of specimens that really includes not only those with chronic symptoms, but those that have fully recovered and healthy controls, because that's the most powerful way to pick out a biosignature and find what's truly different between those. And we hope to do these future studies as we build that biorepository. So speaking of biorepositories, I wanted to make sure you're all aware of the PD LymeNet or Pediatric Lyme Disease Biobank that Lise Nigrovic has built. This was published in the CDC Emerging Infectious Diseases Journal in 2020. And it's really a network of emergency medicine physicians across the country in areas that are enriched for Lyme. There are 8 centers, and there are probably more now. But it's predominantly based out of children coming into emergency rooms. And she reported here that they had over 4,000 kids that had come into these emerging rooms and were able to enroll 500 into their, 800 into their biobank. Sorry, enrolled 3,000 and actually had data for 3,000, but actually have biosamples for 830. And this, I'm sure, is much higher now. Our center is not part of that biobank, but this is going to be a very powerful biobank to be able to also do some of the studies that I was alluding to that we'd like to do in our study. And this is some of the metadata that they're collecting to go along with that biobank. So they'll have all the basic demographics, basic history of what presentation clinically that they're coming in with, the physical exam at that time, any 30-day follow-up and treatment, lab testing, and other linked samples that were collected. So really a powerful thing and unique to have specifically for pediatrics. So, and if you'd like to look at the paper, she goes into more detail about the distribution of age, sex, ethnicity, etc. But it's a very robust database and biobank. So then I was going to end, because we only have 30 minutes, to talk a little bit about fetal and congenital Lyme. This is really a big area of interest when we go to different meetings. And I will preface this by saying that Dr. Sarah Mulkey, who's one of our fetal and neonatal neurologists, who's really one of the foremost national and international experts on congenital infections, specifically Zika, she and I worked together very closely to build a cohort in both Colombia and in the United States to study the exposure and then long-term neurodevelopmental outcomes of this congenital infection, Zika, during pregnancy. And she's now fully independent and doing this work, following these children out to 8 years, along with our dedicated research coordinator, Megan Williams, who's working very closely with her. But we decided to take that model that's been so successful and powerful to study the outcomes of Zika and think about, could we assess this with Lyme? Because again, even though Lyme is the most common vector-borne disease in the United States, and people have talked about potential vertical transmission, there's really nothing beyond case reports to really look at how common this is. And, there are multiple case reports that say there can be abnormal fetal or infant outcomes, or that the placenta has evidence of spirochetal infection related to Lyme infection of the mother during pregnancy. But the bottom line is, we just don't really know for sure how often this occurs, or if there's a specific congenital syndrome. And, because the data is mostly from case reports, it's just, hard to make any specific conclusions, but it makes sense that there might be transplacental transmission, because we know, for instance, syphilis, which is a spirochete, is definitely transmitted vertically. So there's biologic plausibility, there are case reports. And so now we wanted to try to look at this in a more systematic way and include placenta, because placenta is a very powerful way to look at both the presence of an infection, but also the immune response within the placenta, both of which can affect the outcome of the infant. Because even if there's not direct infection, if there's significant inflammation or blockage of the usual nutrient or inflammatory milieu between the woman and the infant, that can have an adverse outcome on the child, whether it's during the pregnancy or later on as they're going through their educational years. So, the other problem is treatment of Lyme in pregnancy is problematic. The first line, we can't use doxycycline in pregnancy. It's class D because of potential adverse effects on the fetus. But we can use amoxicillin or ceftriaxone during pregnancy, and that's what's used mostly for pregnant women. There have been other studies, about a decade ago, that showed treating gestational Lyme disease actually can potentially improve outcome. So this was a study of 100 women, of which 66 received parenteral antibiotics and 20 received oral, and the untreated women were 7 times more likely than the treated women to have an adverse outcome. So this was a signal that, potentially this is an area that we should explore further. The variability in findings between case reports and retrospective and prospective studies is problematic, but in case reports, all of these things have been reported. So prematurity, stillbirth, rashes in infants, congenital heart disease, brain injury. But again, these are all retrospective, and we don't have prospective studies to make any, really firm conclusions. So this is what we're trying to embark on at our center. And this is part of one of the pilot studies through the Lyme Clinical Trials Network, which the Cohen Foundation has funded, with Children's National being the pediatric site and Columbia and Hopkins being the adult sites. And we meet and work together very closely, and we developed the study together. And this is, if you're interested in this, you can scan this barcode and get more information about what's going on with the study. We've just started enrolling. And these are the eligible patients will be participants from US and Canada who are currently pregnant and have been diagnosed with Lyme during this current pregnancy, or who have post-treatment Lyme disease syndrome that's been diagnosed by a clinician within 3 years of the current pregnancy. And again, I want to say this up front, we're not saying that these are the only groups that can have an effect or be affected by this problem, but we want to really, for this initial pilot study, focus in on the most clear-cut cases where the time that it could have been passed to the fetus or infant is occurring right now or in the recent past. And what will happen? They will get pregnancy monitoring. We have the ability at our center to do very advanced and beautiful fetal MRI and ultrasound to look anatomically as the baby develops. We'll get birth outcome data, do placental pathology. The infant after birth will get MRI and ultrasound, and then get detailed neurologic and neurodevelopmental assessments from Dr. Mulkey, who, as I mentioned, is very experienced in this with other congenital infections. So if you know of anyone who's eligible, please reach out to us. I put the contact information here, and we can certainly share these slides later, but we're very excited about this study. So, to take home points from what I've talked about today, children are one of the most commonly infected age groups, particularly that 5 to 9 age group. The range of clinical presentations in children is similar to adults, but we seem to see more incidence of meningitis and a lower incidence of carditis and radiculopathy. The incidence of PTLDS is still really not known, but from our initial, the 100-person study, it seems like it's around 10%. But in general, children do well, and the vast majority do recover, which is also equally important to share with families who are often panicked, with even a simple initial diagnosis of Lyme, even before the child is treated. And then the knowledge gaps, but we're trying to address that along with other centers. We're looking at outcomes research. We're trying to develop biobanks across the country. We're trying to look at specific treatment modalities in pediatrics. And I just briefly Lise Negrovec is leading a multi-center study of which we're part, where we're formally evaluating doxycycline orally versus intravenous ceftriaxone for treatment of meningitis. You know, a lot of people have started doing it, but we don't know in children. So this will be a really important and landmark study. We also in our center are looking at novel ways to assess some of the symptoms, the complex symptoms that patients have with prolonged symptoms after Lyme. So one of our anesthesiologists is with us on the Lyme Clinical Trials Network and has developed some really novel ways to assess pain objectively and be able for patients to actually look when they're being stimulated at which pain fibers are activated, and then with treatment, whether or not that is actually working visually. And the patients love this because it objectifies, rather than asking them, 0 to 10, what their pain is, and validates their pain, that they can see this as an objective finding. And then we are also part of Lyme vaccine trials in pediatrics, which are ongoing right now. And then, as I mentioned, the maternal fetal interface. So I'm going to end there. I do want to just, we consider Lyme one of the the emerging infectious diseases. Of course, it's fully emerged, but there's so much we don't know. And there are so many teams at Children's National that work together in a very multidisciplinary way to address whatever comes up, and whether that was Ebola or Zika or acute flaccid myelitis or COVID and MIS-C. We have a long track record of working together in this fashion, and we are now trying to apply that to answer some of these big questions with pediatric Lyme. So I'm going to end there. And
thank you, Dr. DeBiasi, here in Syracuse. Appreciate it.
So if there's any questions, I'm happy to.
Yes, please. The microphones are on both sides of the room. They're probably hot, or we can bring the microphone to you for any questions you may have about Doctor's presentation. Brian Ledet.
Yes, Dr. DeBiasi, thank you for the talk. Very interesting. Brian Ledet, SUNY ESF. I was interested in the meningitis presentation with the children, and I don't know if you can answer this question. So do you think or have any understanding whether the clinical course, the natural history from exposure to the development of meningitis is similar between children and adults?
I don't know the answer to that. And I don't know if anyone's actually formally studied that. The symptoms, other than this, papilledema that sort of in most cases precedes the full-blown, pleocytosis and neck stiff and all that. I don't know why that wouldn't be seen in adults unless it's just missed, but I can't imagine that's the case. So there may be something different about the timing and the pathophysiology of how it goes to the full-blown meningitis, but I don't think that's been evaluated.
Thank you.
Who else has a question for Dr. DeBiasi? In the back row, and then back to Dr. Paulino.
Hi, I'm Heather. I'm from the local pediatric urgent care here in Syracuse. And we're newer to the area. And in the past 2 days, I've learned a lot about Lyme disease. And so my awareness is definitely up, a little overwhelmed with the information. And hearing about the immune responses with Lyme has really made me aware that early detection and treatment is so important. So from a business owner's perspective, and I have one of the providers here with me, is there anything that we should be putting in place in order to be a bit more aggressive about identification and treatment?
I mean, honestly, awareness and education are the most important thing, because as we looked at 70% of, if you take all reported Lyme, 70% is that recognition of that rash. And the biggest misconception we see, even here in the Mid-Atlantic, which is a big area, is someone will look at a child coming in with a very classic rash and say, well, we're going to send a Lyme serology test and decide if we should treat you or not. And we know that only 10% of those kids are going to have a positive test because it's an antibody test. And when you have that localized rash, there is no antibody response yet. It's just there in your skin. So like just that alone, teaching every single doctor in the United States, urgent care, ER, that is a look at, recognize, treat. That's it. There is no testing, that would be, that captures a large percentage of kids or adults that get missed. Now, if you don't have a rash, which is, could be up to 50%, some people feel, but at least, 25, 30% of people never see the rash because it's in a weird place or, that they don't see. Then this recognition of these other presentations becomes important. And and knowing, that's why I shared the pediatric, like, if you see a child with a headache and papilledema, we automatically in an experienced and kind of high prevalence area, like, wow, that's going to be Lyme. We know it. But if you don't know that, you don't know it, and you start looking at other things. So I really think education, awareness, and data, that's why we wanted to try to get some harder numbers so that people have something to hang a hat on, not just, search the internet.
All right, another question right there in the middle, and then we'll go to Dr. Paulino. Wes Kufel.
Hi, I'm Wes Kufel. I'm an infectious disease pharmacist with SUNY Upstate. I just had a question regarding doxycycline use in children less than 8 years of age. So the American Academy of Pediatrics said up to 21 days is appropriate for children less than 8 years of age. But I just wanted to see what your preferred regimen is for treatment in that population specifically.
Yeah, we do follow that. And we do not see the issues with dental staining, et cetera. So that's, that was clear for those not aware. It used to be that we kind of just said, oh, never use doxycycline in someone under 8 years of age because it can affect the enamel and children can end up with grayish teeth. But, after looking at it over decades of use, it's fine to use it for up to at least probably longer, but at least up to the 21 days. So for instance, if we have a child with arthritis, if they were going to get a full 4 weeks of treatment, we would do 3 weeks of doxy and then switch over to amoxicillin for the last week. If it's an older kid, we would do the whole thing, doxycycline. And I also wanted to say to the person before, I forgot, I'm at Children's National in DC where there's a lot of Lyme, but 20 years ago, I was in Denver at Children's in Denver, and there was literally almost 0 incidents of Lyme. So just like you, I knew nothing about Lyme, 20 years ago, because we just didn't have the patients and the volume. So anyone can become educated. I applaud people that just admit, like, I don't know enough about Lyme. It's not something, there's so many nuances to it. You can't just like read the chapter and say, okay, I'm ready to treat Lyme. So I think it's, you shouldn't feel daunted by like, wow, I just got here and I've never seen it. You'll see it. And when you start seeing volumes of it, you become much more experienced. And then you need to share that knowledge, with other people so that they are also educated.
Hey, Roberta, it's Chris Polino,
Hi.
SUNY Upstate. One comment, one question or clarification. So the comment, I'm wondering if the reason we don't see the papilledema and the intracranial pressure elevations is because a lot of times when people come in with meningitis in the adult population, even when we ask for an opening pressure, we may not get it. And unless they have actual visual complaints, we won't get an ophthalmology evaluation. So I'm wondering if that's part of the reason. It might be there, it might not.
It's possible. Yeah.
Yep. The clarification in terms of the fetal outcome study that you have, I know that you guys prefer to get people down there and to do a lot of these tests routinely down there, but it's something where I think you had mentioned to me before that you can maybe do a one-time visit down there and then have a lot of this stuff done remotely here in Syracuse and then transfer down there. Is that correct?
I think that's correct. Dr. Mulkey and Megan Williams are really like the gurus of all the fine detail, but definitely just refer anyone and we will include anyone that meets the criteria and include them in any way we can. And we are very experienced at, telemed. We evaluated, we continue to evaluate for 8 years, 100 kids in Columbia without physically, we've gone there at least annually or semi-annually, but the rest of the time we're doing it by telemed and even by training the centers in Columbia and fitting their MRI to do the same, type of MRI that we do and then beaming them to us to read. So I'm sure there are creative ways to work this out. But I do think there probably have to be at least one visit in person, but please don't not refer because of that concern. We can let you know on a case-by-case basis if that's possible.
Other questions for Dr. DeBiasi? I don't see any hands. Well, I do see one right there. Okay.
Hi, Cynthia Steinem. I'm a pediatrician here. I'm wondering how the overlap affects children, your area, if they have had Lyme, just the rash, say local, let alone anything more serious, but have recovered, and then they later get COVID. Do they have a much worse case or any effect at all that you know of?
We haven't looked at that systematically, but I will tell you in our long COVID clinic, we're capturing all kinds of data, including, other co-infections or preceding infections. I haven't heard Dr. Yance, Alexandra Yance leads that clinic, and her preliminary stuff, I haven't seen like an enrichment for prior Lyme infection, but I don't think we've looked at that systematically yet.
Thank you, Doctor. Anybody else before we invite Wes Kufel up? How about another round of applause for Dr. Roberta DeBiasi?